My name is Olivia Curlewis. I'm a registered nurse by profession. I've been with Cansa for almost 25 years. On the 1st of June next year it will be 25 years. Then I've gone into my quarter century. It started off I started off right on the ground, being the nurse, doing the pain control, working in the area, seeing to patients. In actual fact, being the jack of all trades. I'm now in management, but still got my finger on the pulse of patient care, because that's where my passion lies. And yes, it's something, cancer is very close to my heart, and it's something that I feel extremely passionate about. I have been affected by cancer itself. My husband passed away from cancer in 2012, and then my son was also diagnosed with testicular cancer about 5 days before his 30th birthday. But yes, he's in remission, he's well, he's good. So I've had the good and the bad of cancer, and I often feel I don't know what the world, what South Africa would be without this organization, because we really walk the road with the patient from diagnosis. So people often they compare us, or they get mixed up with hospice and cancer. We're two totally different organizations, and we've both got a role to play. Hospice zooms in more into the palliative care, the end of life care. Cancer is from the time you are diagnosed. So if you are sitting in front of an oncologist today and the oncologist says to you, you have cancer, you absolutely freeze, you go blank. I can remember, I'm a nurse, and when my son phoned me and said the doctor just told me I have cancer, immediately I froze. All my knowledge of knowing what to do all went out the window. I then became a mother, and I then could put myself in the shoes of a mother or somebody or a family member whose loved one has been diagnosed with cancer. And it took a while for me to put myself back into that vision. Yes, I have got the knowledge, I have got the information, I need to walk this road with them. And that's what we do with the patients. We meet them at their point of need. Sometimes it's just information. They want to know, what is chemotherapy, what is radiation, what is it's going to entail, how am I going to deal with the side effects, what's going to happen when my hair falls out. Yes, we can fit them with a wig. What's going to happen, when my joints are sore and I've got nausea and I don't know what to do. That's where we will meet them. We will say, this is what it's about, these are the side effects, this is what you can use. You're going to get sores in your mouth, we're going to give you, remedies that you have at home that you can use or whatever. So we meet the patient. Often the patients at that time just need the support. We then allocate them maybe to a support group or thing. As the cancer progresses or they get better, that's how we go. If it progresses and they need pain control, we will then assist them with the pain control. If they need medical equipment at home, that's the whole thing outside there that you see. We've got hospital beds, we've got mattresses, we've got sheepskins, we've got everything that will help them there. We will do home-based care, meaning not that we can supply 24-hour care, but we can go and assess the situation at home and say, okay, this is what you need, and that we can supply X, Y, and Z to make it comfortable. We don't look after the patient, but we empower the family, show the family how to wash the patient, how to turn the patient, how to maybe do very simple dressings or something like that. So it goes about empowering the family and how to do that. If the patient has to go for radiation is usually for 6 weeks, and it's every single day. And a lot of our patients can't afford, because radiation is only given in the big centres. So if I look at Gauteng, our patients coming from the West Rand, Carletonville, Fockville, all around here, if they state patients, they will be treated at Charlotte Macleke, which is our big centre for radiation. If they're private patients, they're either going to go to Flora, or they're going to go to Garden City, something. We've got a home away from home. It's a home where patients can stay. And this is just where I've just said, we're Department of Social Development. They give us a grant for that home, because it's the poorest of the poor that get admitted to Curlewis. It's in Belgravia. It's not a nursing home. There is a criteria. Patients must be able to feed themselves, wash themselves, dress themselves. But they will stay there for the 6 weeks while they undergo their radiation. Because if we don't provide this home, they're going to default on their treatment. Because number one, it's going to be costly for them to drive in from a Fochville, from Cartonville or wherever to go there for their treatment. So they're not going to go for their treatment. So they stay there for the 6 weeks. They get 3 meals a day. They get social support. They get emotional support. They get spiritual support. They have a nice bed to live in. They've got a beautiful garden surrounding, and that's why we call it a care home. It's where they stay while they're undergoing treatment. In Gauteng, we have one in Pretoria as well, so if they're getting treatment at Steve Biko, it all depends on what type of treatment. We have one at Steve Biko. I'm specifically just talking about Gauteng. If we're talking cancer nationally, we have 12 of these homes right through the country. We also have our TLC lodges. This is specifically for children that are diagnosed with cancer. We have a TLC lodge at Steve Biko, and then we have one in Polokwane, and then also one in Durban and one in PE.
So that's 4.
That's 4 of them, yeah. They, this is where often, because it's a child, you know, the mother cannot, you know, she needs to support her child. And then she might have other children, their siblings, you know, so I mean, so she needs a place. So these lodges are where the mother and the siblings can stay while the one that needs treatment is undergoing treatment. So it's also just a home where patients stay. And yeah, these lodges are really, how can I say, sanctuaries of just love and support, where these mothers and the siblings, and often these siblings going through a very hard time, because you must remember the child diagnosed with cancer is now suddenly getting all the attention and everything from the parents, and rightly so, because that's the child that's sick. But there are siblings that need that, and they're also scared, they're afraid, they don't know what's happening. And this is just where everything is put into context, and where multidisciplinary, it's looked at the family in a context. Yes, and then we have, at the moment, I said we've now gone into COVID, so we've become very much more, how can I say, electronically digitized, or what everything is that we can now. So we've now just launched our telecounseling line, where people can phone our toll-free line. Oh, no problem.
Hello.
People can phone our toll-free line, which is 0800 2266 22, and then they can make an appointment with a counsellor. So these people are all being qualified, that are on the that are giving the thing. They've got clinical background, they've got social background, they've got things and give them emotional support, and we will meet the point.
Let's just hold on. Sorry about that.
Okay, as I said, we've got our, we've just launched, we're very proud of our telecounselling line. It's all the people that have, they've got, it's a 24-hour line, so people have slots that they can phone in, almost like a helpline, you know, of some sort, where people then phone, they then make an appointment to say, well, this is my need. So we then find out, is it an emotional need? Because then we need a social worker or a counsellor. Is it a clinical need? Then we will have somebody with clinical background or clinical knowledge, be it a nurse or a doctor or someone that has that thing. So they make an appointment, they then get a time slot, and Cansa will phone them back, and then they will have their session for this. It's totally free service. It's a wonderful service, so anybody can access this service, and we're very proud of that. Our support groups, as we say, we like patients, because in a support group you have like-minded people. They're there, people that have been diagnosed, have walked that road, they know, and they can give each other support. In this COVID time, we have found that WhatsApp groups are working fantastic. So where a group used to meet physically, those people all set themselves a WhatsApp group, let's call it the Rudaput support group, and now I'm on it. I'm on about 6, and if I see it's good night, kisses, this, that, hello, here's the sun shining, then someone will say, okay, I have mouth sores or a very dry mouth, or what should I do? And then they all give the information. And if I see they're going a little bit off the track, then I will, so I give them the medical thing, knowledge behind that. So our support groups play a very, very important role, because that's how people support each other. And also it makes the patient feel that they're not alone. They're not in this. They're not the only one that's been diagnosed with cancer. There are so many people out there, and as soon as in the beginning, they're very apprehensive to talk, so they almost become observers. They're just observers in the support group, and then eventually they start testing the water, and then they start giving the support, or they can speak from their experience or whatever happened. And it's so wonderful to see this. We even have a Facebook one called Champions of Hope, and the survivors on this Facebook, and they actually become one big family. It's a cancer Facebook group, and and when one passes on, or one has been in remission and then gets diagnosed again, how the others all come together and give the support to this one person is unbelievable. Or someone will just throw out on a specific day and say, guys, I can't do this anymore. I'm throwing in the towel. No, you don't do that. You're going to do this. You can get through this. We're here for you, and this and that. It is wonderful to see. And the very shy people, as I said, they sit there as observers for so long, and they just see everybody else as me, and then eventually they grow into, they get the self-confidence, and then they start giving advice or giving the thing like that. Then of course we have corporate wellness, which is also, we were very, very worried about this whole thing, because this is an income for cancer. Corporates, as you all know, have a corporate wellness fund, most big corporates, and they will to see the wellness of their corporate. So they will approach Cansa and they will say, we've got so many females, so many males, we need pap smears, we need breast examinations, we need PSA testing, which is of course the blood test that's done for prostate cancer. It's a marker, it's a blood marker. We need the breast light, we need a photo finder which analyzes molds and that type of thing. So they get like a request form that they get sent. This gets sent to the corporate. The corporate will then tick off, because there's a cost involved for everything. But Cancer is taking wellness to the corporate. So a lot of these women would never have gone for their pap smear, because they don't have time to take off time from work or whatever the thing is. So the wellness is taken to the corporate. The corporate will book out a day. It's all done on an appointment basis. And we were very concerned with this whole COVID, because suddenly, we were always very busy, and suddenly with this whole COVID thing, were corporates going to have wellness? Were they going to? Do they still have the budget for it? Because we all know the economy has gone pear-shaped. But suddenly now the corporates are phoning in and saying, we need wellness for our staff. People have gone through a very tough time mentally, and thing is, so they are almost looking at, how can we give back to our staff? Let us book wellness for our staff. So we get the booking form, we will quote the company and say, this is how much it's going to cost, because remember, we've got to have registered nurses, and if it's a big corporate, we can have up to 6-7 registered nurses on a day doing the screening, because we have to be COVID compliant. We have to see that everything is, that there's sanitizing, that there's enough space between all the clients, that the beds are sanitized, that new linen is put over, that the staff member or the registered nurse doing the screening, that she's got screens and she's got enough protection to protect herself as well. So that is also a service offering that we have. And then we have community screening, which is where we go out with our mobile unit. But that is usually a funded screening, like an APSA, or a corporate will come on and say, okay, Seriti Mines or something will say, okay, we're prepared to give you X amount to go and do pap smears in this area. Because remember, there's a cost to the mobile, there's a cost to the driver, there's a cost to the fuel, there's a cost to the consumables we use, there's a cost to the nurse. So we do a little costing that we then send the project plan in. They will then it's a free screening. With corporates, the corporate pays for it. When we go into the community get it for nothing, because they can't afford the screening, and therefore it's usually funded by a corporate. And that's our community screening. And then we have screening at our clinics, like I'm talking about Roodepoort at the moment. We have screening twice a month here, where people will phone in. Yes, they're going to pay for it. Yes, they can claim it from their medical aid. But if anybody over here decides to go, I need a clinical breast examination and I need a pap smear, it's a cost that the doctor is going to cost you, which can be anything between 600 and 1,000 rand for that consultation. Then you've got to pay for your the procedure taken, which can be about between 400 and 600 rand. Then you've got the lab fees, so it can be anything between 1,000 to 1,500 for a woman to go for a pap smear. Cansa will do the breast screening plus the pap smear, all costs included, meaning Lancet, and you get your results back within 24 hours, and that is done for 360 rand.
Wow.
And within 24 hours, because we immediately, it's done that day, we take the specimens to the lab, and within 24 to 48 hours, depending on how busy the lab is, we get the results back, and we will then phone the patient and say, this is your lab. How does it help the patient? She doesn't have to take a day of work. She doesn't have to, and even those people that don't have medical aids, that have to go and sit at a clinic where it's for free. How long is she going to sit at that clinic? She might have to be there at 6 in the morning, and if she's lucky, she's going to be screened today. Or she might be sent home and then told to come back the next day. And maybe the next day, or maybe she's gone, and they say to her, okay, but today we don't do screening. Today it's just mother and baby immunization, so come back on Friday. Now she's paid the taxi fee, she's paid everything, and what is she going to do? She's going to default. She's not going to go for a screening. So that is where we have the offering that we can do at the office. It is absolutely so well, how can I say, the interest from the community. We're fully booked up, everything. We're even thinking of now going weekly. We were only doing it twice a month to try it out, but we're now going to, almost, we'll probably here from October go weekly, because we're fully booked up every fortnightly.
How often should you be screened?
For a pap smear, it is, well, the Department of Health says only one every 10 years, because that's what Department of Health can afford. So they say from the age of, you should have your first screening 30, then 40, and then 50. But we found that a lot of people are diagnosed with cervical cancer at much earlier, because women are becoming sexually active at a much earlier age. Well, not women, but girls, young girls. And therefore, we all know that the HPV virus is one of the biggest causes of cervical cancer. It's caused by the human papilloma virus. And this virus can be eradicated, and that's why we have that vaccination program that is rolled out at school. So girls between the ages of 9 and 11, before they become sexually active, are advised. It's two vaccinations that they get. So they are then but a lot of the parents are very anti this. Oh, you're now going to let my daughter become sexually active. No, that's not. We want to prevent cervical cancer. And so it is a program that Cansa fully endorses, and we're not sitting on the fence about it. We do say, please send your children. Even in places like Australia, boys are being vaccinated because they are usually the carriers of the HPV virus. It's not a deadly virus, it's not something, but it can cause surgery. And in actual fact, a statement was made by the World Health Organization that if every girl was vaccinated, we would eradicate cervical cancer. And that is one of our biggest percentages at the moment. Our highest incidence is breast cancer, which is 1 in 28, but cervical cancer is very close behind it. Then we have, we go out a lot to the schools where we promote this, where we tell the girls, you also need to know your body. You need to be able to know how to do a self-breast examination. And it's something, nurses like I am, and as my children always said, Mom, you're so gross, you just call a spade a spade. And often when we go to a school, we've got to keep that in mind. These are youngsters, so we take the girls apart and we take the boys apart. We're not talking in a mixed group about about the girls' breasts and the boys, because what is testicular cancer? Testicular cancer is a young man's cancer. It's usually between the age of 15 and 30. It's between the ages of 15 and 30. So who are our target to to tell about testicular cancer are our youngsters at school. They need to know that they need to examine themselves. They need to know. And I just want to go back to my son that was diagnosed with testicular cancer. The children, the boys that are usually at high risk are babies that are born with undescended testes. So that meaning the testes, they are they've got they up in the groin, and when the baby is born they descend, because then they're going to get too hot, so then they go down. Now some babies, that little cord is too short, so it means that they don't descend. So those children are usually at a higher risk for testicular cancer. That operation to lower those testicles are usually done between the birth and 3 years old, but they are at a higher risk. Now my son was never at a higher risk. There was never any family history. There was never anything. And he told me what made him go to be tested, because there was no pain involved. He had a bit of discomfort, and he thought maybe his jockeys are too tight, or whatever the thing is like that. So he had but he remembered in his mind that his mother always used to say to, and they hated it when I said to them, I always said, guys, because I only had boys, guys, have you checked your goodies? And they used to say, Mom, you're so gross, the thing is, and that is what saved his life, because he remembered that. And when he had this discomfort, I always used to say to them, it feels like a little small pea, a pea that you eat? It feels like that, and it doesn't have to be painful. And he felt that, and immediately, this is a guy that's almost 30 years old, made an appointment for himself, went to see a urologist, was diagnosed with testicular cancer, was in theatre that same afternoon, had his testes removed. And that, so if he had left it, it could have spread.
What are the symptoms of ovarian cancer and breast cancer?
Oh, well, there's so many symptoms. With breast cancer, it is obviously, the first thing is to feel a lump. And when you feel a lump, and that's when we say you must know how to do a self-breast examination. We teach the girls, they lift their arm, they lie flat, or they can do it soapy in a shower. They've got to feel, because the breast tissue goes right under the arm. They need to be able to feel their breast, and they know it. And any young girl will in the beginning feel a lot of lumps, because breast tissue is lumpy. But as she gets to know her body, she will differentiate between her cycle, when her breasts are heavier and things, or a lump that she actually feels that is, that the thing is, and then that's not supposed to be there. So obviously it's a lump. Then we have also the nipple when it retracts in, because obviously sometimes when there's a growth there, the nipple. Now some girls are actually born with retracted nipples, and doesn't mean that all retracted nipples mean there's cancer. But if you always had a normal nipple and suddenly it's retracting, that's an indication that something is not right. When you have any discharge from the nipple, when we have what we call this orange peel effect, that meaning on the breast, you suddenly see this, when you get this cellulite on your leg, and it looks like you've been hit by thunder on your leg. Well, that's the same on your breast. It gets this orange, it gets like little dimples. And that means there's something behind it that's pulling the skin in. One breast lower than the other. Breasts are never totally symmetrical, but when suddenly there's a change, one breast is lower or one breast is suddenly a lot larger. Now a lot of girls will not have total symmetrical breasts. They will have one that's slightly, but it is something that they've noticed all the time, and it's not a change. But where they've always noticed, it's quite the same, and suddenly there's a change, that will mean that we need to. And 9 out of 10 lumps are not cancerous. But we cannot ignore that one. Yeah. So therefore we always say, if you feel a lump, it must be investigated. It doesn't mean if you've got a lump that it's cancer, but it must be investigated. Now ovarian cancer, this is all hormonal, so a lot of it goes hand in hand. The hormonal one, where she has pain in the side, maybe a lot of almost, how can I say, spotting and that type of thing. But all this is linked with this the symptoms for ovarian cancer, cervical cancer, uterine cancer are so interlinked that you need to take a whole history before you can really make it, and in actual fact do an investigation before you can decide, okay, this is something that we need to look into.
So the one is harder to diagnose than
Oh,
the other one.
absolutely. Cervical cancer is a very quiet cancer, but there will be, spotting and bleeding when there shouldn't be, but usually there's no pain involved. And that's what makes it so daunting, is because there's not any discomfort or pain.
Okay. What is the most the most difficult part of your job? From your side, from Cansa side?
From my side as a person, and now I'm talking about over all the years that I've been at Cansa, is dealing with a child with cancer. It actually breaks. As a mother, I actually put myself in those parents' shoes. And that to me is absolutely heart-rending. Because a child is so innocent, a child doesn't understand what's happening. And then that mother, to be able to have to walk that road, she's going to need a lot of support. So that to me is very, very, very difficult. Is dealing not only with the child, but with the parents of that child. And it's something that I was, it's something that I don't wish any mother or father to have to go through.
What would you say is the one that stands out, the most difficult part for a patient, for someone with chronic cancer, in the entire process?
In the entire process, I think that, or you're not talking about a family member that needs to deal with this?
With the patient themselves. So
What's
they find
difficult
out.
for the patient?
So they find out they have cancer. From the start, what's the most difficult thing? Dealing with it? Is it maybe the chemo? Is just something that breaks a woman most often? If that makes sense.
Oh yeah, that makes sense. You know that, as I said to you, when you hear the words "you have cancer," it's something that you have to process. It's something that the thing is, you often leave those rooms feeling, my life's come to an end. I've been given a death sentence, and then you have to need to start processing it. And often they need some time to first process it, and then to be able to come back and then say, okay, now I need to put an action plan in. The most difficult, I think, is sometimes blaming yourself, saying, why didn't I go to the doctor earlier? Why didn't I do this? Why didn't I see the symptoms? Why did I neglect myself and this and that? And this is something that I always say to the patients. You have to let go of yesterday. You cannot blame yourself, because nothing is going to change. Nothing is going to change about yesterday. We can't go back and change the past. And we also don't know what the future holds. So we're going to deal in the present. And that to me is the most important thing for a cancer patient to understand, is to be in the present and to deal with today's issues today. Because tomorrow is unknown. Yesterday has gone by. We don't know what we don't know what tomorrow holds, and yesterday we can do nothing about. So if today I've had chemo and I've got nausea, I must deal with today and not say, but what am I going to do next week? Or how am I going to deal with the finances next week? Or what if my medical aid runs out? Or what if or how am I going to deal with my children? Or what this? Those are all what ifs. We cross the bridge when we get there. We do give patients a lot of things, and especially if it's a mother with young children, or maybe children that have still got their whole life ahead of them. I've just had a friend that passed from cancer. She's got 2 girls who are not married. What I told her to do is to make a love box, because she knew she was not going to be around. She knew she was not going to be there for the wedding. She knew she was not going to be there for the birth of the first grandchild. She knew, but I said to her, you can still be part of it. And it's very difficult as somebody from the outside saying, because now you're almost confirming. But they already know where they're at. They know they've reached a point of no return. They know whatever treatment they're getting now is not curative. It's palliative. It's giving me a better quality of life, but it's not there to cure me. But then you put them in control of something. And she passed away in January. And she's got the most beautiful love box that she's put together. And in these, for every milestone, when they get married, when they get engaged, when they get married, she's got a message for that. She's got the message for the birth of the first grandchild. You know, those are all little things, memories that she's put into this. You can call it a memory box, you can call it a love box, you can call it whatever. And I know just before we died, she said to me, Olivia, thank you that you gave me this idea, because this really empowered me, and I feel that I've given my daughters the tools, not the tools, she's not obviously giving them life skills, but they will not feel at their wedding day, I wish my mom could be here, because a piece of her is there, and it could be a letter, it could be a voice note, it could be a memory of something, it could be something that she made that she's given to her daughter.
Do you have questions?
Okay, so I asked about how often you should get a pap smear, or when you should get.
Oh,
When
yes,
I asked that.
I asked you, and then I didn't actually
yeah.
answer it over there.
So pap smears and mammograms.
Okay. Depending on, so pap smears, we say if you're in the private thing, we would prefer you to have an annual pap smear.
Okay.
If you do go for a pap smear, and they do pick up what we call aplastic cells, meaning that there's a little bit of there. Doesn't mean it's cancer, but the thing, we will then say to you when we give you your results, come back in 6 months' time, because sometimes there's a bit of inflammation or something could cause those little cells. So you could come back in a month's time, and then maybe the next smear is clear. But a breast examination should be done monthly. A mammogram, if you have you got a family of history, remember breast cancer is genetically linked. So if you've got a grandmother, a mother, an aunt, a sister, someone that has had breast cancer, you immediately put into the high risk. So that means you should have your borderline mammogram at the age of 35 and thereafter yearly. If you are not in the high risk, we say you have your borderline mammogram from the age of 40. Why do we say only from that age? Because before that, young girls' breasts are very dense. The older we get, they're less dense. That's why they start going south. so it's more difficult to see that. But when we have a borderline one, then it's easy to look, and then it should be done on an annual basis. You should have a mammogram.
Why does the age only start at 35?
Because of the density of the breast.
But is it not possible to get it younger?
You can get it younger, and that's where your self-breast examination comes in. But for a mammogram, we say the only thing is. But as I say, I mean, that is just what we sort of throw out there. But if you really have a very strong background, I mean, we've had girls at the age of 18 diagnosed with breast cancer. And therefore, that's why at school, girls should learn to examine their breasts.
If a 20-year-old comes in and asks for a test, would they be shown away with this?
No, not at all. But you see, we don't do mammograms. You think mammograms are these huge, big machines that are only, you know, in very, and they
They squish you.
They literally squish you. So those are very, very expensive machines that are done. They are done by Pink Drive. You've all heard of Pink Drive, where they have these mobile units going around. And Pink Drive has their place, and they have whatever that needs to do. But we have just found that a lot of the people will have those mammograms, but they never get those results back. And I'm not slamming anybody, I'm just saying that it is a blockage in the system there, I think. So, you know, if I send somebody from, usually during October, there are a lot of the radiation departments that will say, we will do it at a reduced fee in this month, because everybody's focus is on breast cancer. Then we will advertise it and we'll say, Flora, Krugersdorp, wherever thing is, are doing it at a reduced rate. Please, ladies, remember, go for your mammogram.